Good evening, and welcome to The Caring View, the online health and social care platform, free to access for anybody in the sector, wanting to join the sector, or living using social care. We're here to educate, elevate, and celebrate all things social care. Before we get started, if you're watching on YouTube, hit that subscribe button and tap that bell. You'll get notified of all of our video uploads and live episodes and when we plan our events. If you're watching on Facebook, once again, I am so sorry, the link is not working. And if you are watching us on LinkedIn, make sure you follow us as well. Go to www.thecaringview.co.uk for all of our podcast episodes, our YouTube chat show episodes, our free resources, our supplier list, our exclusive CQC hub to help you through the new framework, and contact us there as well. It is your go-to place for everything free that we offer to social care. I'm Adam, one of your hosts, and I am joined by my co-host,
Mark. Hello, everybody. How are you?
I'm good, Mark. How are you? And tonight we have a very special guest with us called Tom Calderbank. Good evening, Tom.
Good evening. Thank you very much for having me.
You're most welcome, Tom. Welcome to join us. So before we get started, I'm still shocked at this. I've just had a nearly 4-hour drive back from Leicester, so I've not seen any news, and I listened to an audiobook on the way home because I am sophisticated, I am cultured, and I listen to audiobooks, Scandi Noir, so nothing, amazing. It's not like Homer. National living wage from April next year, £1.44 instead of £11.44 instead of the £11 they previously announced. Mark, thoughts?
I think there's going to be a lot of the small providers that are going to be really impacted by it. I think we were talking kind of just before we joined about whether or not local authorities are going to kind of pass on those increases in fees. And I don't know, I look around at like Birmingham and the other councils that have kind of declared themselves bankrupt. They're definitely not going to be able to afford to be able to do those increases. Very strange because obviously, like you said, they've announced one rate. So local authorities are already working their budgets to those rates. So it's even whether we're going to find out in time for budgets, whether or not you're getting an increase, what that increase looks like. But yeah, I think the only thing that's going to happen is it's just going to push more of the social care sector to go private as opposed to local authority, which then causes a postcode lottery, a money lottery, and a whole load of people that are without care.
Lots and lots of panic providers, I think, this evening, especially seeing as, again, we were announced £11, so a lot of work will have gone into planning for that already. I must say also a quick shout out to the Southeast who have got the new CQC framework from today. Let us know how it's going. If you are one of those homes that are going through the new framework, we'd love to hear from you. But talking around being shortchanged in care, around care costs, Tom, I love segues into conversations. Tonight, we're talking about foot health. Has the care home sector been shortchanged for too long? Now, Tom, I want to ask you, before we get started and talking about this, the most important question you are going to be asked this evening, okay? Is it chiropody or chiropody?
That is an excellent question. I mean, I think if we could answer that, we're done. Or what's the difference between podiatrist and chiropodist, which is probably the one that I answer all the time. But chiropody, because it's from the Greek chiro.
Oh, I knew you'd have the answer. What were you, Mark? What side of the fence did you sit on?
Obviously the right side. No, I was chiropody, and I'll probably call it chiropody tonight. I'm not going to get my head around changing the terminology tonight.
Well, we're talking around podiatry tonight, I believe, Thomas. So talk us through this title, Foot Health. Has the care home sector been shortchanged for too long?
So this is really about just some issues around foot care in the care home sector that I came across getting on for 3 years ago now. I mean, I'm just to introduce myself, I'm a podiatrist by background. I've been working as a podiatrist for the last decade and a half, most of that time in the NHS. I've gone from being a specialist, almost all my career, I've been a specialist in biomechanics and neurology, and latterly in biomechanics of the diabetic foot. But over the last 2 years, I've sort of found myself working in the social care sector and setting up this business, Care Home Podiatry, for the reason that about 3 years ago. So I've been working as an NHS podiatry manager for about 5 years towards the end of my NHS career. And was happy doing that. I loved working for the NHS, great place to work, and there were lots of opportunities to kind of make positive changes and improve the way things worked in podiatry departments within the NHS. And I was busy doing that when I got talking with a friend who ran a care home, and he asked me, well, we got talking anyway about foot care. He didn't know I was a podiatrist, so we got chatting. And he asked about fungal nail infections. And he said, everyone in his care home, almost every single resident had a fungal nail infection, these kind of brown discolorations, kind of crusty looking nails. And he said, is that just normal? Is that everyone who gets as they get older? I said, well, not really. It's common, but it shouldn't be everyone that has that kind of infection, and it's an infectious thing. So after our chat, I agreed to go in and have a quick look around his residence, just to offer a little bit of advice and maybe see what was going on. And after inspecting a few people's feet, and yes, they all had fungal nail infections, I got chatting to one of the nurses and asked about kind of their foot care provision, who provided it, what was going on. And they had a provider, as it turned out, that would turn up every 6 weeks and go into the residence lounge, go armchair to armchair, chair to chair, treating every resident with a little bag of equipment, be there for a couple of hours, finish up, say bye-bye, and off they went. So I started kind of prying and asking questions, and, were they using clean equipment? Well, apparently this person providing foot care had this tiny bag, so there's no way they had 30 different sets of instrument with them. There's very little infection control. There was no handover to the nurses. They didn't really know what was going on, what was being provided. And this really shocked me, because, even the nurse, while we were discussing it, said, oh, actually, yeah, that doesn't seem right. But because that's what they'd used to, that, they'd had the same provider for like 20 years or whatever, someone they knew really well, knew all their residents. They just never questioned, well, that's just what happens. Every 6 weeks, this foot care provider turns up, cuts everyone's toenails and goes. And just, with my NHS hat on, working in NHS at the time, I was thinking, this is mad. Like, where's any information for you guys? Where's the infection control? Who's kind of monitoring this? So I had that discussion with my friend, the manager of the care home, kind of advised what you might do. And I looked into it, and I kind of looked, what are the regulations for care homes? Why the information is out there for social care providers? And actually, there was absolutely nothing. Like, I could almost find, like, there was nothing to find on the internet. And then also, kind of chatting with the manager, my friend, about what he knew, which is nothing really. And anyway, so that was that. I gave him some advice, and I cracked on with my NHS job, and it just kept eating away at me. Like, something needs to be done about this. It's really. There's a lot of people, potentially, if this is the practice everywhere, there's going to be a lot of people really receiving substandard care, and there's no one even looking at it or addressing it. So I kind of made this information pack, and I was like, okay, I'll just publish this on top of my, while I keep doing my NHS job, I'll make some information, and that'll be that. And I just didn't know where to send it or who to give it to, that it would make any kind of impact at all. So in the end, I just thought, you know what? Maybe I'm ready for a new challenge. And although I love my NHS job, I just was called to like do something about it. It's something that I always did in my NHS work, was kind of find problems within NHS podiatry and go, okay, what can we do? What simple thing can we do to fix that and make it better? So this, I was like, okay, this is an opportunity to really make a difference to a lot of people, which led me on to kind of setting up our company, Care Home Podiatry, but also kind of working to improve the sector more generally. So I can give you kind of a nutshell. Having now started the business and spent some time looking at foot care and care homes and understanding the sector, which is a real minefield, by the way. Coming from the NHS into social care is just trying to work out who to talk to, who's responsible for this, what document you look into for this, and how people make decisions is just, it's a real minefield, and it's very difficult. It's great having people like yourselves making podcasts like this to like highlight things I should be reading or listening to. So,
well, while you were talking just then, Tom, or Thomas, which is it? Thomas?
Tom is fine.
I never want to misuse people's names. But while you were talking, then I had a number of things come to mind, and I don't want to take us away from podiatry, because this is what the show is all about tonight. But all I could hear in my head was dentists.
Yes.
Because Just like podiatry, dentistry is so hard to come by within social care. They all tell us that we need to manage oral health as well as we can, but point us to someone that can take care home residents and people who live in social care, or visiting dentists, because a lot of people are chair-bound and bed-bound, for example, and still need that good oral care. Doesn't exist. So I'm really interested to learn more about your initiative this evening. So talk to us a little bit around your company then. What does your company provide and what do they offer? Shameless plug. Come on.
What might be more, if I can give you kind of a really quick rundown of what some of the issues are, and then I can kind of explain why we're doing what we're doing, and that might make more sense in terms of just so you kind of see where we're coming from and why we're doing what we're doing. So yeah, definitely Smiling Matters is one of the first things I came across when I started looking into it and went, God, you can literally cross out oral care in every one of their findings from that Smiling Matters snippet and write foot care, and they apply. And just that's it. That's exactly it. So much the same, really, but there are some other confounding, other real issues that also kind of make the situation a little worse. So I'd say, in regards issues with foot care in care homes, what we found is there's very, very little guidance. So no guidance or regulation on what's happening out there. So managers don't have guidance. So you're not told what you should be providing. So foot care is a sector you don't necessarily know anything about, and you're told nothing about what you should be providing. So how do you know what you should be getting in for your residents? There is no laws or regulations really governing it. So there's nothing stopping anyone turning up to care homes and offering foot care. It's not like dentistry, and this is one of the ways it differs. In dentistry, your dentist turns up and does your teeth, that's it. In foot care, although you have to be, essentially there's no law stopping you turning up and saying, I can provide foot care. If you get yourself some insurance, get yourself a certificate from a course, or nothing really, and you can provide foot care. There's no law stopping you, there's no regulation on that. So that just opens the doors to kind of the standard being very, very hit and miss across care homes. So you find lots of different professionals or people providing foot care, not just podiatrists. So to make it really clear, I'm a podiatrist. Podiatry as a profession is also called chiropody. They're both protected titles in law. So you can't call yourself a chiropodist or a podiatrist unless you have a degree and you're registered with the HCPC. So that's a healthcare profession council. And they're the people that monitor podiatrists, physios, occupational therapists, that type of thing. So we're the kind of one monitored actor in the sector. On top of that, you have a kind of a myriad of people with varying levels of qualification. So that lack of regulation there is an issue, and that causes a big variation in the standard and safety and quality. On top of that, there's that just general lack of awareness. So care staff, nursing staff, and managers don't necessarily know what it is about foot care and why foot care is important. So I think, unfortunately, and I understand why, care homes are really busy places and you've got lots of important things to look after. So thinking about or knowing about feet is probably the last thing on agenda, but there's a lot more to foot care than just needing to trim everyone's toenails. And if it's not done properly, or to put a positive spin on it, if it's done properly, it can really positively impact people's health. And if it's not done properly, there's a real risk of people are going to lose limbs or their life as a result of improper care. So lack of guidance, lack of regulation, and then as a consequence, lack of awareness of people running the services. And then thirdly, and this is where it differs from NHS dentistry a little bit, is issues around access. So NHS podiatry, you would think, would cover a lot of foot care. Foot care is important. People living in care need help with their foot care. You would think it would be covered by the NHS. Unfortunately, that is the case to an extent, but the NHS actually only provide a really, really small portion of foot care, particularly in care homes, because like everything else, their podiatry departments have to focus down on what they can provide with the resources they have. As a result, over the last 10 years, and I've personally seen it and been involved in those decisions myself, we've really had to like slim down what it is that NHS provides. So in care homes, it's about 5% or less of care is going to be provided by the NHS. And then everything else then is private foot care. And that's where it really differs from dentistry. So dentistry, in that Smiling Matters paper, one of the issues were that people perceived that there's a financial cost, and the finance was a barrier But in actual fact, NHS dentistry is paid for. It's NHS. And so there is no financial barrier. But podiatry, there is a financial barrier. So if you don't have money to pay, unless you live in one of the few care homes or care groups where they include foot care and room cost, unless you have the money, you don't get your feet looked after. So there's a big chunk of people that are going to have an issue with access to what is basic care as a result of not having money. And then on top of that, just to add another layer in terms of access, podiatrists are really hard to come by. So there'll probably be people watching that have this experience and might be watching because they're thinking, I really need to get someone in. And podiatrists are really hard to find for the reason that there just aren't very much of us. We're a profession in decline. In the last 5 years, there's been a 15% drop in the number of podiatrists. A lot of my colleagues are coming up for retirement. And although there is work behind the scenes to bring the numbers back up, there are less and less people doing podiatry, and more, as podiatry progresses as a profession, less people are doing what's seen as the more basic side of care, such as kind of routine foot care. So more podiatrists are doing the kind of biomechanics, MSK, foot surgery stuff, and less people are being attracted into social care to do kind of the more routine foot care. So there's just a lack of people. So you can see that regulation, lack of knowledge, and then access issues really is like the perfect storm. And that's essentially what motivated me into setting up care home podiatry. And I'm really sorry that I'm going to be talking loads now, because now I'm going to answer your question, Adam. Do you want to jump in? Do you have any questions on that before I jump in about care home podiatry and what we're doing?
I just want to know, what are the risks associated with biting your toenails? I used to bite my toenails when I was young. No. In all seriousness, it's very, very true. And, a lot of the problems that we don't even think about. So falls, for example, frequent falling. One of the things we fail to look at is things like foot health. Diabetes, huge problem. People with sores on their feet, cuts on their feet, not healing properly. And it's really important that we monitor it like that. So actually, we need to look at podiatry and chiropractic as like a holistic thing, rather than it just being, let's have nice, neat toenails. So I think everything you're saying is ringing true to myself and probably care homes around the country thinking, why don't we think about this more? And why isn't there a Smiles Matter paper for foot care?
Yeah, definitely. Absolutely. I completely agree. Which is, brings us nicely on to exactly why we set the company up. I mean, so we've kind of got two parts of the company effectively, and we're doing our best to pedal both sides as best we can. So we've got the actual business podiatry part, where effectively we're just trying to provide good podiatry care to care homes that to the standard, and kind of using my NHS experience with that side of it, just providing good care. We're not doing anything fancy. We're not using like magic laser machines, or I was at the care conference and everything's like a special laser for looking in your ear, or like magic chairs that sense when you're sleepy or something. There's all technology, but we're not doing anything fancy, nothing special. We're just providing really consistently good foot care with people who are properly qualified, i.e. have a HCPC registration. We provide them with kind of the oversight and training so that the issues and the needs of people living in care, the unique needs of people living in care, are kind of, and using our expertise to make sure they know how best to address people's needs. And also providing a governance structure, because private podiatry in care homes is it's disparate. It's very patchy. Essentially, every care home will have a different person working in it. And even if that person is a qualified podiatrist with the right letters and HCPC registered, doesn't mean that there's not going to be still a huge variation in the quality and what's being provided. So we provide that kind of governance structure around our podiatry service. So looking at making sure our infection control, there is an infection protocol for infection prevention control, making sure they're all working to the same kind of clinical standards. We've got like an incident reporting system in place, which isn't going to sound anything to all of the care home managers, because you think, we all have to do incident reporting, but that doesn't happen in a system where every care home just has an individual podiatrist who just does a bit of private work. So we're trying to address some of those issues and provide that structure effectively. And Another thing that side of the business is doing is facilitating podiatrists into social care work. So a big barrier for podiatrists doing care homes is actually just the logistics of having the equipment and the stock and the record system. So to be a podiatrist doing a bit of private, if you were an NHS podiatrist, for example, and you wanted to do a little bit of private work on the side, care homes are actually quite tricky to do because you need at least 30 plus sets of instruments, somewhere to sterilize all those, somewhere to keep all of that. You need some kind of record system and managing all those records, along with the requirements for all the the IG requirements. So it kind of puts people off, I think, doing social care work. So we're trying to facilitate people into those kind of, encourage podiatrists to take up work in care homes by providing the equipment, the record system, the guidance around it. So that we're also just providing outcome reports, foot care plans for every resident. So a bit like an oral care plan. So leaning on some of the advice from Smiling Matters, we provide foot care plans for every resident. For when we're providing across a group, we'll provide foot care policy that they can include as part of their policies. So yeah, kind of the whole spectrum of foot care. Just, as I say, nothing fancy, just the basics done really well. So that's the podiatry providing side. And then the other side of what we're trying to do is just to make a difference, because we know that on our own, as many podiatrists as we can employ, and as far we can kind of have an impact by just providing podiatry, we have this campaign. So the campaign for better foot care, that we're trying to push a little bit more from this week to try and work to educate care homes around what they should be doing, what they should be providing, maybe some of the pitfalls of not providing good care, providing kind of information, free downloadable bits and pieces, so they can share that training with their staff, or like tick lists to go through to kind of evaluate their own foot care services, that type of thing. So education, we're trying to, and this is kind of a long job. We're trying to encourage the CQC to take a little look at foot care in care homes. Like you quite rightly said, Adam, this is crying out for a Smiling Matters paper. Actually, it's quite tricky to encourage the CQC to do anything, particularly as a private company. That your emails do fall on deaf ears, unfortunately. We have had a little bit of email back and forth with Mary Cridge, which has been really encouraging. But on the priority list of things in care homes, unfortunately, foot care, to try and get it bumped up is pretty tricky. So we're trying to encourage CQC to take a look at it through a Smiling Matters type deep dive paper, because unless you really understand what's going on out there, change isn't going to happen. And thirdly, we're trying to encourage care home groups where we can, and this is a really long shot, to embed foot care in room costs, because foot care shouldn't be a luxury item. It shouldn't be like, oh, Pat's paying for a perm this week, so she isn't going to have her essential foot care. Foot care should be an essential part of care. So we believe, potentially, ultimately, maybe it should be centrally funded by the government, the NHS, out of that budget. But we believe it should be centrally funded, because we know that the care home groups, where they do include it in room cost, it just works so much better. There's no barrier there. People get regular foot care. It's done properly. So that's on the campaign side, educating people, encouraging that CQC deep dive, and just kind of talking to groups and working with groups to encourage them around the funding thing. So in a nutshell, that's us.
That's a very large coconut shell.
Yeah, I'm sorry. I'm really conscious that was a really big spiel, so I apologise.
No, it was good. It was good. Sorry, Mark, over to you.
No, I just wanted to kind of touch on the CQC element there. So when you were kind of talking at the very beginning about the lack of resources, I was just thinking that's kind of everything in social care. And it was only the other day Adam and I were talking about, actually, for me, the frustration with the regulator is, why don't they have templates and tools that all care services can utilise? So actually it's really standardised. Adam was saying about that you get a recommendation to put something in place, but nobody has that template. And I think that's where our Freebie Friday initiative came from, because actually there were just so many managers saying, we don't have this and we don't have that and don't know where to start, and people are charging 200 odd quid for a form or a guide. somebody thinking, actually, we need to do more around foot health. You've obviously got a guide. Is that available on your website for them to download?
Not yet. So we've decided to try and relaunch our campaign a little bit to kickstart it again. So this week we'll be starting to put stuff out through the campaign. We have what we wanted to do was have a separate website for the campaign, so it was a little bit clearer away from our own website. But obviously, resources and time has meant that will be included as part of our website. But yeah, that's not. We have one. We had one out previously, but we're going to kind of republish that in the coming weeks. So that will be coming out. So we'll definitely be sharing that on our socials. So if you guys would kind of push that, that'd be fantastic.
Yeah, no, absolutely. So anybody thinking about kind of a policy around foot health, and I'm just thinking, I don't think my organisation has a policy around foot health or a protocol, and I suppose we're slightly different because we're reablement, so we're not really kind of doing that side of things. But is there anything that should be included?
So there are some real essentials that I think care homes miss a little bit. And Adam, you kind of mentioned diabetes, and that's kind of the one really. That's the one biggie, and one where there's already guidance in place that care homes miss. So, the answer is yes, there should be a foot care policy in place to cover all foot care, because there are lots of issues: falls, diabetes, kind of ambulation, keeping people on their feet, that type of thing, keeping people active is all related to feet. But yeah, diabetes is the one already that there is policy there and people aren't aware of. So CQC will often look for annual diabetic foot checks in your residents' care plans. So an annual diabetic foot check is just exactly what it sounds like. So everyone with diabetes, so every single person, regardless of whether they're insulin dependent or take medication or don't take medication, is meant to have an annual foot check. And the annual foot check is a simple form that can be completed by a nurse or a podiatrist that looks at the risk factors for developing an ulcer on your foot. So an ulcer, a diabetic foot ulcer, effectively is a very, very serious thing, to the point where the 5-year mortality rate of developing an ulcer, so a wound on your foot, is about 75%, so worse than some forms of cancer. So if you're diabetic and develop a wound on your foot, it's really, really serious. So as a result, nice guidelines are that everyone with diabetes has this annual diabetic foot check. So it's just a screen for risk factors and flag people to make sure they're getting the appropriate care. And CQC will look for that on your residents' care plan. If you're a manager, I'm talking to you, your residents' care plans. So if your foot care provider is not already providing that, so us as a company, as standard, we just provide that anyway when they're due. But you could embed that into your nurse training. Your nurses could actually do those for you, or you could encourage your GP practice to come out and do those. It's just making sure you're recording that and having a copy of the outcome of that. The other thing around diabetic foot that I often see care homes get wrong is what to do when there is a diabetic foot ulcer, what's called a diabetic foot crisis. And it's no one's fault, essentially, but NICE guidelines are really, really clear that as soon as someone develops a wound on their foot, they have to be referred within 1 day to what's called the MDT, diabetic foot MDT, so multidisciplinary team. So that's the diabetic foot multidisciplinary team at the hospital. So every hospital trust will have the diabetic foot team. They're essentially a diabetologist, a consultant diabetologist, a vascular surgeon, an orthopedic surgeon, all working together with a specialist podiatrist to, as soon as possible, address and get on top of diabetic foot wounds, because they can go wrong very, very quickly. The mistake I see a lot of care homes make is that they will refer all wounds to tissue viability, and then they're not always appropriately referred. And when I've seen kind of tabletop reviews, and when I've been involved in tabletop reviews of when diabetic foot ulcers have gone wrong and someone's lost a leg or lost a foot or lost their life, when we've reviewed kind of what's happened, delays in referral to the MDT are always there. That's always part of it. So yeah, if you can do 2 things, annual diabetic foot checks, and if you get someone with a diabetic foot ulcer, you've got to know the pathway to refer them into diabetic MDT. Normally, that will be available on your local NHS podiatry's website. So if you Google NHS podiatry for whatever area you're in, there will be like an email or a guide to how you refer there.
Thank you very much. And my follow-up was, is there a cost associated to any of those, or are they part of the NHS that are funded? Just thinking back to your comments earlier around money and people's choices and bits and pieces.
Yeah, so those bits are absolutely provided by the NHS. The difficulty when talking about what's provided on the NHS is that there's huge variation across the country in terms of inclusion criteria, but diabetes and particularly diabetic foot crisis are absolutely provided on the NHS. That's absolutely free of charge. To generalise, and this won't be the case everywhere, but we'll just give you a rough idea. So the way podiatry departments work is they'll have an inclusion criteria that will be something like this. So either you need to have a condition that puts your foot at risk, or you need to, such as diabetes, rheumatological disease, or a vascular issue, or you need to have an acute foot problem, such as an open wound, a painful corn that can be addressed. If you don't have those things, so if you just need routine foot care, often you won't obtain NHS foot care. Now, that varies a little bit. So it may be, so actually the area I used to work in, Sandwell and West Birmingham, because of the nature of the population, we actually did a lot more routine foot care than most. But that is essentially, that's how that works. Well, one thing we are trying to, when we do when we are providing care into care homes, just additionally, is help care homes understand where that border sits. So we do ourselves refer into NHS podiatry at the threshold where the people meet it, to make sure people are making the best use of the NHS care where it's possible.
I was just having a look on the NHS website, even the website for podiatry. It's not the most amazing, is it, on the NHS? Like, there's no, you think there'd be kind of guides and not best practice, but kind of outsourcing, kind of like even to the NICE guidance that we've shared in the comments, but there's none of that. When I was listening to you earlier, when you were talking, all I could think about was probably the number of care homes that just receive a phone call from people that say that they specialise in feet, do they need a service, and kind of that telephone sales and the amount of people that probably say yes. One question that comes up time and time again that I see on all the manager groups, I think it's been a question ever since I joined social care, is can a care provider cut toenails? And it always comes back to a risk assessment around diabetes, which we've obviously just spoken about. What would your advice be if a care home was to ring you and say, actually, are we allowed to cut Mr. Tops's toenails?
So, in a word, yes, because there is no law stopping anyone providing care. So anyone can provide foot care, and that's often a misconception. Like it's sometimes easier for care providers to say we're not allowed, because that makes a clearer rule. What I would say is, so an individual risk assessment would have to be done on every person to check whether, what might be the risks of you delivering foot care to them. So do they have a vascular issue? Do they have diabetes? If they have diabetes, do they have some of the foot risk factors, such as loss of sensation, problems with their circulation? Do they have changes in the shape of their foot, so foot deformity that's causing pressure points that need addressing? So for that reason, it's really difficult for us. Like we always say, foot care should all be provided by a podiatrist, because it's really, where we've discussed putting in place where care homes can deliver their own foot care, the sticking point is always, how are you going to assess your whole population, and then continually reassess everyone to check whether they're appropriate for the podiatrist, they need podiatry care, or whether they're okay with someone trimming their toenails. And how is that person trimming toenails, with the best will in the world, expected to identify when something goes wrong? So there are the obvious ones. If there's something big and red and oozing on your foot, then but some of the more subtle things. So like some of the value of using a proper podiatrist is that, for example, we can, if we notice subtle color changes in the foot that might indicate a problem with circulation, we could then whip the Doppler out, do a quick ultrasound Doppler scan right there, and that can give you information on the potential that someone might be having some acute ischemic problem in their foot. You can diagnose atrial fibrillation, so irregular heartbeat, just through checking someone's pulses in their foot, which can then relate to having a stroke, for example. There's loads of things you would miss out on, I think. So yeah, it's very difficult in a very low risk population. Then yes, but it's just having those safety checks in place. I just don't know how you would facilitate that effectively.
I mean, it's an absolute minefield, isn't it? I mean, my personal stance is just a huge no, because there's so much that, like you say, we miss out on if we do it ourselves. But not only that, let's think the grimmest of grim. If someone sadly dies and it's to do with falling, for example, and actually they fell because the feet were sore, where were the feet sore? Well, they were cut doing the toenails. Who did the toenails? The care team did. What training did they have?
Yeah.
Oh, absolute minefield at coroners. So realistically, we're looking for what's the registration you're saying? Podiatrists and chiropractors need chiropractors. That's my bad back from driving today. Need to have.
So that's HCPC, the Healthcare Professions Council. In fact, I'll drop a link in the comments now. So it's really easy to use their website, actually. All you need is the surname of your provider and their profession, so chiropodist, podiatrist, and it'll give you a list of everyone with that surname, because podiatry is not the largest profession in the world. It'll give you a list of everyone with that surname. So you could go on and search me right now, and it'll give you their professional registration number, including any additional qualifications they have. And if they're not on that register, they don't have a degree level qualification in foot care. That makes it really, really simple. Who's qualified can be a really confusing thing, even for the professions themselves. So we'll often speak to care homes and they say, "Oh yeah, we've seen the qualifications of our provider. They've shown us certificates. They're a chiropodist," and it's just assumed that they're a chiropodist because they do foot care. And actually, when you look at the certificate, it'll say foot health practitioner or something along those lines. And whilst there are foot health practitioner courses out there, and some of them are quite good and quite comprehensive, there's no kind of standardization there. So you could obtain that certificate by doing a short online course, or you could do a year of qualifications for that. So just to make things really simple, we always advise care homes to only use HCPC registered professionals, because not only do you then know that their degree is qualified, but also the HCPC regulates them. So if your podiatrist is not doing good practice, you can tell the HCPC and they will take them off the register and they can't practice anymore. For everyone else who's not a podiatrist, that's not the case. There is no register. You know, if you chop someone's toe off as a foot health provider or whatever you might be, and then your care home sacks you, there's nothing to stop you going to the care home next door. So knowing that your podiatrist is on the HCPC, although it doesn't cure everything, at least it gives you some knowledge and some assurance of that they're meeting some basic standards, such as their infection prevention control work, keeping up with their continuing professional development, that type of thing. So yeah, that's the key. As I say, I'll pop it in the chat now.
So realistically, I'm just thinking around the big groups out there. You're talking at the beginning about including podiatry and chiropody within room costs, and £11.44 a side, and not really sure we're going to get the room rates to meet that national living wage, let alone additional costs that we want to absorb into it. And then we get into care poverty for people who are state funded and can't afford top-ups and all of that. For the large groups out there, there's nothing really stopping us then hiring a fully qualified podiatrist or chiropodist as part of our group working. Because if we had, say, 6, 7, 8 care homes, we could easily hire a group chiropodist who works solely within those 8 care homes, providing that adequate, consistent foot care.
Yes, and I think, definitely something we're pushing is for care home groups to. I run a company that sells foot care to care homes, so I would say it's great if you use us, but a single provider is a really good idea because you can standardize that cost. There's one number for you to call. Something, if you don't like the way something's done, you can change it across all your homes. So yeah, there's definitely merit in that. I'd say the difficulty with employing someone is that you would then have to do all of their providing training for them, keeping them up to date. If they leave, you then have to find another one. The way we work is that we're a foot care provider. So if you used a company like ours, for example, we would provide you with a name podiatrist, and if they were off sick, we'd provide cover. Whereas if you had as an individual you were employing, there would be no cover. If they're off sick for 6 months, you would be then trying to find someone else. So there's merit certainly. We have some employed podiatrists, in some of the areas where we're more densely populated. But most of our podiatrists are actually contractors working with us, working under our framework. So they'll probably be doing, most of them are NHS podiatrists that do a little bit of private work for us. And we find that works really well. But I agree in that having one podiatrist across your homes makes absolute sense.
So I'm a provider. Well, I am a provider, but let's just say, for this scenario, I'm a different provider. I'm going to act daft on this. And I'm sat there going, oh gosh, we do nothing really on this. I've only just got over the Smiles Matters stuff, and that was a headache. And now I'm thinking, feet, crikey, what am I going to do? What does good foot care look like? Just the basics of what good foot care looks like. What am I supposed to be looking for?
That's a really good question. I hope I can give you a concise answer here. I
hope so too. And I'm joking.
So for starters, as we've just been talking about, using a regulated professional, so using someone who's under the Healthcare Professions Council, at least you know that they have some kind of profession. Then making sure that you have on file their DBS check and their insurance, as those are basics, but they do get missed. And then after that, I would then be thinking about having an agreement in place between your provider and your home. So this is actually the one area where CQC do actually have some advice on using external providers. It is only advice, so there's like a web page about it. So if you're using an external provider like a podiatrist, it's recommended you have an agreement in place. And that basically just sets in writing what they are providing, what you are providing, just to make sure there's nothing lost in between, there's nothing lost in translation there. You know that this is what they're going to be doing, this is how often they're going to be turning up, this is how they're going to practice, this is how much it's going to cost. So that agreement just shores that up and makes sure a bit of continuity in care for you. Then further to that, I would be looking for an initial assessment and record of that for every resident. So it's easy for me to just tell you what we do in care and podiatry because I believe that's kind of gold standard. So for every resident, I would provide a foot care plan. So that's an assessment that looks at their foot health, identifies any issues, and then puts in place a plan that covers what your provider or foot care provider is doing and what you are doing as a care home to maintain their foot health, including any risks. Then at every subsequent visit, I would include an outcome report. So information detailing everything that's happened to make sure there's a good flow of communication between yourselves and your provider, your podiatrist, or whoever might be providing your foot care, to make sure, for example, that care can be followed through. Because podiatrists, they do we turn up between every 8 and 10 weeks generally for our care homes. So most of foot care is done by the care home themselves. So having a good understanding about what you should be doing as a care home is going to have the biggest impact on people's foot health, not actually your podiatrist, because they're only there once every 8 weeks. So the daily stuff. So that leads me nicely on to having training for your staff around some of the issues in foot care, and having like a daily check to do. So there is actually a really good resource that I've recently posted on my LinkedIn by NHS Scotland around a simple check you can do every day, just like a checklist, a bit like the skin checklist, to make sure that your residents' feet are looking okay. And then further to that, I would include foot care into a foot assessment as part of your falls assessment documentation. There's, as you've said a couple of times, Adam, and it's actually backed up by the literature, like the scientific literature, there's a link to foot problems and falls. So you're much, much more likely to have a fall if you have a diagnosable foot condition. So, and there are actually a couple of named examples. So having those as part of your falls assessment is really important. And then training for your staff, I think, is also a really biggie.
Just listening to you there, I just want to kind of, Adam, unless you've got any follow-ups on that, I just wanted to kind of talk about training, because you obviously mentioned earlier there's a decline. I was then just kind of on the HCPC website there, just kind of looking. There isn't that many places that do the training across the UK.
To be a podiatrist,
yeah, really low numbers. I was looking kind of in kind of like my region. There's absolutely none. Seems to be a lot up north, but Sadden, you could get a side hustle here going. You'd be okay. But yeah, if you're down kind of southeast, yeah, there's not many places that offer it. What would your advice be if there's anybody thinking, actually, because we know there's a number of care home managers that are either kind of bordering retirement or thinking of, actually, I don't know if this is for me anymore. I'm looking at doing something different, but they want to stay in the sector and they're thinking, actually, this is something that interests me. What would your advice be in terms of upskilling and training?
So one of the really good initiatives that they've recently brought out, I say recently, probably the last 5 years, they've started to push, is actually podiatry apprenticeships. So an extra route. So there, as you say, there aren't many places to do podiatry, and you do have to go and do a degree. You can obviously do that part-time as any other degree if you want to do it alongside other things. So it's either a 3-year full-time course or 5 years as a degree. But more recently, with the Royal College of Podiatry and Health Education England, they've been pushing the podiatry apprenticeship route. So you can go and be a effectively working podiatrist while training, which is a really, really good route into it. As a company, it's not something we've actually started doing yet, but it's part of our strategy over the next couple of years to start taking on podiatry apprentices, for the reason that we find podiatrists hard to come by, and so when you get good ones and you've trained them, you really want to hold on to them. So it's a good way for us, and it's something we will be doing in the next few years. But yeah, that's kind of a good route in there for people who are maybe wanting to transfer those skills. It's a good question.
So let's scale that training back a little bit more then. So we talk about all this training for team members within our own homes and providing that good foot care within our own homes. Even less training around that in social care. So I don't know of any foot care training course that's provided to social care. You do a quick Google search and it's all around foot health practitioner courses.
Yeah.
Do you know of any training out there for care home team members, for your normal care staff, your senior carers, even your nurses, on how to provide that good foot care within a care home setting?
No.
Are you going to create one?
Yeah, no. So one of the things we're working on is a training package. So we're going to have some online courses that we put on for people our clients effectively will have access to online training courses, and we do offer training as part of what we provide. But outside of us, no, this isn't training. It's not something that's provided, and those are the types of things that probably would get driven by a CQC review, for example. Because the people that provide social care training, because there are companies out there that provide social care training to social care, aren't there? They would then go, oh God, we should probably have a module on foot care. So I think it's probably. I'm not saying we're like early on the bandwagon or anything, but I think it's just something that's flown under the radar for so long. There isn't anyone providing anything on foot care, and that's why we're really trying to bang the drum and do everything we can. And it's just. We're working really hard to provide everything, but 2 years into, or 2.5 years into this business, we've got lots of things coming up and we're working on, but it's getting them all out there.
So just on that then, and I'm not going to try and steal all your stuff before you've got it up on your website and it's there running your business, because that's what it's there for. What are the sort of things as managers, as care home providers, as supported living, or anyone really working in social care, what are the sort of things we can be doing to train our team? What should we be asking them to look out for, and what sort of competencies to give us confidence should we be looking for when going through foot care with our teams? Because most of us do ad hoc training, be that at handovers or team meetings. We do lessons learned when we have incidents that have occurred. So what sort of things should we be saying to our team members? Look, this is really what you need to be looking for now, and this is how we're supposed to be doing this to prevent things happening in the future.
So I think first off, again, to go back to diabetes, it's obviously identifying everyone who's diabetic, and everyone who's diabetic is meant to have a key worker. Is that correct? Is that already in place? So is that right? Am I wrong?
Well, I suppose it probably differs up and down the country, and depends on whether you're a care home or home. I bet home care providers, I bet a lot of people that are kind of live in their own homes don't. And I wonder how many of them just kind of, a bit like you said about the service, just fly under the radar because they actually don't really access the GP. Or if they do access the GP, it's not about their feet, it's about something else.
Yeah, so I would recommend for every, this is again, so I apologise to home care providers, because we often get loads of questions from home care providers, but we provide specifically to care homes, and that's where my head is. So apologies if you are a home care provider. But so I would recommend for everyone in the home that has a diabetes diagnosis that they have a worker that specifically helps to coordinate their care. So you know that they're your diabetic residents. And then that worker then can have some extra training. You can give them some extra information around the importance of diabetes and foot care. But the same stuff that applies to diabetic feet really apply across to everyone. So I'm just trying to secretly see if I could find that resource that we posted. Where is it now? Basically, the checks should include a visual check of the resident's foot. So the key places really are the back of the heel. An easy way to do that for people lying in bed is if you've got a small mirror, just to lift the resident's foot up, dangle the mirror underneath their heel, and you can have a little inspection around the heel looking for signs of any. Yeah, and I mean, you guys already probably know the signs for pressure sores, but non-blanching redness, any loss of skin, changes in color, heat, those types of things. So looking for any changes to the skin integrity, and then around the foot, looking between each toe for any signs of dampness, discoloration, issues. And again, for care providers, I often say that it's not rocket science, but if you were doing a daily foot inspection, when something's wrong, you will know. If you are checking every day, you will know when something's wrong. In fact, I will bring this up, and I hope not to gross anyone out too much, but one thing I do always ask all my care homes to do is that their carers clean between people's toes, because you say, oh, you think that should be a thing, but you won't believe the amount of kind of debris that gets built up there, because if someone's bedbound, they're not walking around, you don't shed your skin cells, and so you get this whole like a mass of stuff between your toes, and that's a big infection risk. In that's a great place for bacteria to grow. Between your toes is a common place to get splits, so that's a really common place to start a tissue infection that turns into cellulitis. So cleaning between residents' toes is a really commonly missed one. All you need is like a cleaning wipe, and you like floss between each toe, and you're going to really massively reducing people's risk of developing infections, fungal infections, and like. That's great. And then once you've done that, while you're doing that, you're inspecting their foot. So then tomorrow, when there's something red there, you can go, oh, that wasn't there yesterday. I'll flag that to the nurse.
Yeah, definitely. It doesn't gross me out at all. I find like things like that incredibly satisfying. I remember back in the days when I was a carer on the front line, and I'm going back 15 years now, but even back then, I was so conscious around people in between the toes, and yeah, a little Conti wipe, a bit of a flannel, and just give it a floss, and you can see the amount of dead skin that comes out from that. And for providers that are sat here listening, thinking, oh God, all this sounds really clinical, and I really don't want my residents thinking I'm just going to sit there poking around their feet. Do it as part of a foot care massage. Give them a foot bath, give them a massage, have a real sort of pamper session around it, make it something holistic. And whilst you're doing it, do your checks. Because actually, therapeutic-wise, well-being-wise, activity-wise, they've had something a little bit different. They've managed to soak their feet. They've managed to have a bit of a relaxation. You've had a laugh and a giggle about it. If they so wish, paint the nails as well. Not gender-specific. Anyone can have anything done nowadays. But whilst you're doing that, have a look at their feet and do that as part of your assessment. Make it less clinical, make it less formal, make it less pokey and sort of checkbooky, tick boxy, and make it into a really sort of therapeutic activity. That's how we do most of the things we do. We don't just roll them around and strip them down and check them as if they're a piece of meat. They're people at the end of the day. And actually, if someone came up to me and said, do you want a foot massage? And I soak in a foot bath, yeah, really, really would. Really would. Soak them. You're probably going to get a load of dead skin off them as well. So all in all, you can't really lose out.
Yeah, that's yeah. I couldn't agree more. That's absolutely fantastic. I think often where we'll get pulled up sometimes because there's this kind of blurring between providing like more of a holistic beauty type treatment with what we do, and that's often where there is some confusion, because you will get beauty therapists providing foot care in care homes, and there is absolutely space there to provide that kind of foot massage. like that touch interaction with residents, which is so important. But as a company, we really like draw the line and say, look, we're a medical provider, like we're providing medical foot care. Often we'll get picked up because we don't necessarily apply foot creams to people, and they'll go, oh, I paid all this money, are you not going to massage my feet? And we say, well, we could, but a foot cream really is something that is going to have an effect over weeks. Me applying it today is going to make no difference. It's like your GP going and only taking your statins when the GP is there to give it to you. The foot cream has to be done every day by the care home staff. So, that's why we don't do it. But as you say, it's a great opportunity to have that connection with your residents, and at the same time benefit their foot health. And it doesn't need to be a thing, an extra thing to do, really, is it?
I know. I was going to just come in and just talk about people with a learning disability, because I think quite often we focus on elderly, and I always put my LD hat back on. Around it, is there anything in particular for people with a learning disability for providers to think about? Because I kind of think back about my career, and it was only the care home that I managed kind of more recent years. But when I very first started, I don't think I ever saw anybody come in and look after anybody's feet. I'm trying to rack my brain. My memory is not great, but I'm 99.9% sure I didn't see anybody up until the care home that I took over that ironically was failing, but did have this in place. But yeah, is there anything for people with a learning disability that we should be considering?
So again, a really, really good question, and probably learning disability homes I found are less well provided to, because I think somehow foot care is just missed, because if people are younger, it's kind of like, oh, I don't need their feet looked after. And some of we will often go into homes and perhaps they haven't had someone for a long time. And learning disability homes are definitely one where there's neglect. There's no specific like, oh, this is a really common thing with people with learning disability. It's just really those challenges around providing personal care potentially to people who don't want to have their feet looked after. And my only advice around that is just to use a provider that understands the needs of the people, isn't in a massive rush to get around everyone and get home, and really takes the time to get to know residents and know what works for them. I always say to my podiatrist, I'd much rather them spend, timing and how long we treat for is a completely different issue. But I always say I'm quite happy for you to treat someone quite quickly. If you can do their foot care quite quickly and do what's needed and be out, that's great. But then when you come across a resident who maybe needs an hour because you need to coax them into having their feet done, spend an hour doing it, because neglect is probably the big issue in people who maybe have say learning disability needs is often that's an issue. So I'm just trying to think other specifics.
I guess thinking then though around behaviours that present as challenging as well. So people who have, so let's say their dementia needs outweigh their nursing needs, and typically called EMI, where even personal care can be an antecedent to quite a bad behavioural incident. Foot care is only going to exacerbate that, isn't it? So there's those complexities around this to consider as well.
Yeah, absolutely. And it's just, I think a lot of that's just using that really human caring side, and you can't always train for that, but that's something we work on with our podiatrists, like strategies, things to kind of avoid or do that you can help facilitate. The good thing about kind of us working in the team is that we'll have someone get on the WhatsApp and go, I'm really having trouble with this person. Has anyone got anything that they use? Have you tried this? Have you done this with them? And I think podiatry is a profession that's it's almost lost its core of what we used to do, like general foot care. There's a lot of specialists doing like neurology, rheumatology, biomechanics, and that kind of core of just providing routine foot care has been lost. And there is, I genuinely believe, there's a calling to be a specialist in kind of care home work, in that there are some really specialist skills there around understanding behaviours and things you can do to make, to facilitate that care. And I think there's no simple answer. It's, being an experienced provider who knows potentially behaviours and working with care homes who are the people that know their residents best potentially. If I can go back to the learning disabilities question, I did think actually one of the things that maybe happens in learning disability homes that doesn't happen in so much in elderly care is kind of more mobile pressure lesions and more the biomechanics side, what I used to do. So like foot injury, because if you're mobile, if you're walking around a lot and on your feet, so in elderly care homes, you don't get a lot of painful corns, callus, or you don't get Achilles tendon problems, plantar fasciitis, those types of things. But potentially in learning disability care homes, if people are more ambulatory or up on their feet more, you do. So it's just a slightly different hat on. But podiatrist should be a kind of a multi-specialist profession anyway, so everyone who's qualified should be able to address those things. But it's just a slightly different take on what you need to provide.
And right fitting shoes. You know, I've got a pair of shoes at the moment under my stairs that are beautiful. Like, I absolutely love them. And I know as soon as I put those on in 3 hours' time, I am going to have blisters the size of golf balls on the back of my heel because they're solid leather. They need wearing in. And I've got that awkward foot size where I'm in between two sizes. And they were just too beautiful to let go. But actually, wearing the right footwear, especially for people who are in care, is just another reason that we can get those sores on our feet, isn't it? Sorry, Mark, I saw you going to unmute.
No.
Sorry, Tom.
Go on. I was just going to say, because it came to my head as well, my pet hates is the little red hospital socks. Why is it in care homes that they're seen as like gold standard footwear? Because if I see another resident in red socks walking around, and you're like, if they just stood on something or you run over their toe, there's just no protection there. But for some reason, those socks are like, well, the hospitals give them out, so we're going to order them for everyone. So footwear is a big issue.
I was going to talk about shoes, funny enough, the same as Adam mentioned, because actually when I compare kind of supporting the elderly, you have so many different elderly designed shoes, don't you? I can't think of the life of me, and I've actually seen it at the care show recently, but proper shoes that are fitted for people. Whereas when I think back to kind of supporting people with learning disabilities, because it's all around personal budgets and their money, normally end up at like Primark or Matalan or one of the cheapest shops, because actually they don't have enough money to be able to go and buy a pair of good shoes from Clark's or wherever it is. And actually the difference that probably makes in terms of kind of long-term damage to their feet, because they're not supported shoes and all the other implications that might come with that. I am conscious that we are over by 3 minutes. I'm also conscious that you need to go spend some time with your family. Before we close out, is there any top tips that you want to share that we might not have covered tonight, or one that we have covered that you actually really want to kind of hit home about?
Top tips, good question. So yeah, I mean, my top one, and I've banged on about it a lot, is just check your podiatrist is HCPC registered. So what that's going to tell you is basically minimum they're going to be degree qualified, and they're having to maintain standards to a certain level. And if they did something wrong, or you could report them to somewhere and they could be struck off. Outside of that, you're kind of on your own. You've got to make your best judgment, and there's nothing to kind of cover you there. So check your HCPC registration of your podiatrist or provider. Really, really easy to do. I keep saying provider for the reason that it's boring, but I think in the long run, foot health practitioners might be kind of incorporated in and kind of brought into the more mainstream foot care side of things as things become more accredited. They may end up on the HCPC, and that'd be great, because there'd be more people providing foot care and they would be regulated. But anyway, HCPC regulation, check that with your podiatrist. I would say ask for more from your podiatrist. So don't put up with just them turning up, cutting everyone's toenails and bailing home. They've got to give you podiatrists. If you have a podiatrist, are really, really qualified, so they can, particularly if you're at home without nursing care, they can give you a whole load of medical information. Some podiatrists are quite highly trained and can be independent prescribing, like myself. So they can give you advice on wound care, on diabetes, not just for feet, but more holistically too, on vascular issues, on falls, on gait, on mobility, on footwear. And you can ask those questions of your podiatrist. You're paying for it, or your residents are already paying for it. One stat I didn't get in there: we estimate something like £50 million was spent last year by residents in care homes on foot care. So it's not a drop in the ocean. It's like a lot of money you're spending. So make sure you're getting value out of your podiatrist. That's what I'm trying to say. That kind of harks back to the name of the podcast today. So ask a little bit more from your podiatrist. Anything else? Yeah, that's probably it. Make sure you're utilising the NHS and the private sector properly, because you're not going to get everyone covered by both. But for some elements, you will always need the NHS stuff. And try and utilise that best you can. And also, your podiatrist should be able to advise you on where the NHS stuff sits, because most podiatrists will either have previously worked in the NHS, because most do, or will be currently working for the NHS, so they can really probably give you advice. Okay, this resident does qualify, refer them, or I can do the referral for their nail surgery, so you get them free on the NHS, whatever. There you go. Hopefully that's helpful. We will be publishing some top tips soon. We're going to be publishing a checklist for care home providers to use, so they can kind of evaluate their own foot care services, just to identify where there might be areas to improve on. And we'll be providing a load of other good information, hopefully in the coming weeks, as we can try and get that up to.
And clean between your toes.
Flossing between your toes, yeah.
Flossing between your toes, definitely a must. Look, Thomas, it's been absolutely fab having you here tonight talking about this. For anyone who is interested in the services you provide, you can go to www.carehomepodiatry.co.uk, find out more on there and the range of services. I think you provide packages as well, don't you? It's not just a one-off cost. You provide packages which cover pretty much anything. Go and have a look. All those services are available. And actually, they sound incredible. We've used podiatrist and chiropractic. Dead set on chiropractors tonight. Mark, we need to do a chiropractor show, because I need to get this off my chest for some reason. We've used podiatrists and chiropodists for years, and actually in my old previous services, I can't comment on the services that I'm working in now, but in previous services that I've worked in, they never provided anything like what you're talking about. So really, really great stuff that you're doing. And I can't wait to see your campaign relaunch. We will share that far and wide through the Caring View. And we'll be huge advocates for you moving forwards. This has been the Caring View, the online health and social care platform for everybody wanting to learn more about social care, educating, elevating, and celebrating all things social care. Go to www.thecaringview.co.uk for all of our resources, past shows and episodes. Mark, what are we talking about next week? Get it in your diaries, everyone, as well, for next week. What are we talking about?
What are we talking about next week? We are talking about AI in social care. So this is off the back of the care show in Birmingham in October. It was a really well-received event, and we had a lot of people contact after asking for more. So we've got Jack White, Michelle Corrigan, Sonia Rai joining us. So we'll be able to kind of talk about what's kind of happening in the sector at the moment, things to kind of watch out for in terms of policies and procedures if you're thinking of using things like ChatGPT or Google Bard in your workplace, and just kind of bring that kind of informed discussion as we always do. I'm really looking forward to it, because I'm a lover of AI.
And what a great panel. So we've got Jack White, training provider. We've got Sonia Rai, expert in all things HR, and Michelle Corrigan, like the mastermind behind the Better Care, Better Security, Better Care DSPT toolkit. So no better panel to be able to discuss AI in social care. Really looking forward to it. 7:30, as always, live on YouTube and LinkedIn. Hopefully Facebook next week if we can get that fixed. But until then, thank you everyone for joining us. Thank you, Tom, for all of your knowledge you've brought tonight. And like I say, please be in touch with us. Don't be a stranger, and we will share your services far and wide. Good night, everyone, and take care.
Good night. Thank you, Tom.
Thank you very much. Thanks for having me.